you new to ventilator management? You have no idea what APRV is? I got you. APRV stands for airway pressure release ventilation. And this is where we have long durations of inspiratory holds. We call that the T high, the time we spend at the high pressure, and then short little bursts of exhalation. We call that T low, the time we spend at the low pressure. And we use this not very often. It's pretty rare, and we use this for our super sick ARDS patients. Remember, recently I did a video on PF ratio where we compare the PaO2 to the FiO2, and that gives us a good idea of how sick or how far into acute respiratory distress syndrome our patients are. And APRV is one of those things we can do for the super sick ARDS patients. Well, what's going on in our patients with ARDS? Well, when we have a normal alveoli, it's like a balloon where we give it a breath, and then when those patients exhale, they still maintain this nice round shape. These are very compliant alveoli. However, in our ARDS patients, their alveoli are more like this plastic sack where we try to give it a breath and we can keep pushing and it's not going to stretch out and thin out, so we can diffuse those oxygen molecules across this alveolar capillary membrane. And then what happens when we exhale this? It doesn't maintain that nice round shape like our balloon does. No, it just goes flat. And so how can we maintain compliant alveoli? How can we get these to stretch out and keep them in a nice round shape so that we can diffuse, we can perform gas exchange across the alveolar capillary membrane? Well, we're just not going to let them exhale. Well, not for very long. So normally when we are ventilating a patient, or when you and I are breathing on our own, inhalation, this is an active process. When I'm doing it on my own, I'm dropping my diaphragm, I'm using my chest wall muscles and generating that negative pressure inside my lungs so that I suck in, I generate that negative pressure and suck a whole bunch of air in. However, exhalation, all of those muscles just relax and that air passively flows out of my lungs. Now, when the ventilator is doing it, it's actively pushing in a breath on that patient, but then it's not actively sucking that breath back out of the patient. The same thing happens. We have to let the chest wall relax and that air passively flows out. So normally we spend about twice as much time exhaling as we do inhaling. Think about the way that you're breathing. Fast, slow process. So we spend more time in the exhalation phase. So we're actually going to do the opposite when it comes to APRV. It's a reverse I to E ratio where we're spending a long time during that exhale. And here's what it looks like on these patients. Of course, it's a ventilator doing it and not the patient breathing themselves. But we inhale them and they hold that breath in for T high. So there's only a little bit of time at the bottom of the breath allowing them to exhale. And we have all this time that we're holding the inspiratory breath in. A short amount of time for exhale. And so what happens is we're not giving these non-compliant, crusty alveoli time to be able to collapse. We're holding them open. Short exhale, coming right in with the very next breath. So does that help you understand APRV? I hope so. See you next time.